Good afternoon again, everyone. I'm Cheryl Larson with the Midwest Business Group on Health. We are very excited to be sharing our webinar with you about a project that we have been working on off and on for the last several years, but this is all new and exciting information. Our webinar topic is Employer Lessons on Hemophilia Management. We have a lot of different speakers today that are going to be sharing different perspectives, and I know that you will walk away with new information, new ideas, and new tools. Next slide, please. Next slide. So we always like to share a little bit about MBGH at the beginning. If you don't know who we are one of the oldest and largest employer coalitions in the country. We represent well over 5 million lives, but we're still putting those numbers together. We have almost 190 employer members today, and we are a community of your peers. We really want employers to learn from each other, share best practices, etc., and a trusted source. Next slide, please. For today's program, if you have questions of the speakers, please use the Q&A function. And you can also use the chat function to communicate with other attendees. And if you're having any technical issues, just let us know via chat. The PowerPoint slides will be sent to you after today's meeting. And we will also be including a copy of a new resource that we are launching at the end of today's program. It's a new employer action brief. And then at the end, we'll give you a few minutes to complete the program evaluation. This information is so important to us. Next slide. So as we have been looking at this project the last year, and then previous to this, we launched a toolkit that I'll mention later. The question comes up, why should employers care? And I think it's important for us to go over these key points. The economic impact of hemophilia is significant. It can cost $300,000 to $500,000 or easily exceed $1 million if complications arise or an inhibitor is present for the patient. The plan design plays a significant role in directing the type of quality of care that is received. And by getting treatment through a hemophilia treatment center, we have learned that is the gold standard because it provides comprehensive case management and care coordination from a multidisciplinary team. And if I think about the first round of things that we did with this topic several years ago, that was one of the number one most important elements that we learned about this. And we have a speaker who's going to share more with us on that today. There are unintended consequences of utilization management and AFPs, and these can result, alternative funding programs, which can result in dire consequences for members and much higher costs for employers. For example, a copay accumulator and maximizer program can create steep, immediate out-of-pocket costs for patients, causing them to delay or abandon treatment and seek care in the emergency room. There are also workplace implications, not just for employees, but caregivers as well. And we have to remember that caregivers experience psychological, physical, and financial challenges in this space. The average lost work days is upwards of 19 days per year. And we'll be hearing from one of these caregivers during today's session. And finally, it's just a reminder that it's critical for employers to understand the financial exposure of hemophilia, regardless of whether they currently have a member on their plan with this condition. And by following these basic steps, you're not only going to give your employees and members better care, you're also going to have cost savings by not necessarily doing what your vendor partners may want you to do. Let's get started with our first speaker. Next slide. We're going to be talking about Hemophilia 101, some of the employer challenges and opportunities in managing this high-cost, life-threatening disease. Becky Burns joined the Bleeding and Clotting Disorders Institute in 2016 and currently serves as their Chief Operating Officer. She has over 15 years of not-for-profit accounting and management experience and is a passionate advocate for the bleeding disorders community. She was instrumental in working with the MBGH team and our employers to update our hemophilia resources. So thank you so much, Becky. You'll be hearing more about the online toolkit that we are currently updating and today's employer action brief that we will launch today. Welcome, Becky.
Thank you, Cheryl. So thank you for the opportunity to speak to all of you a little bit about our hemophilia treatment centers and what an employer really needs to know about hemophilia, some of the health economics, and why really directing that care, as Cheryl said, to the hemophilia treatment center is not only the gold standard as far as clinical care, but can have considerable cost savings to employers. Next slide, please. So just a little 101 on hemophilia. According to the CDC, approximately 33,000 males in the US are living with hemophilia currently. Hemophilia A, factor VIII deficiency, is 3 to 4 times as common as hemophilia B or factor IX deficiency. 4 in 10 patients with hemophilia are considered severe, which means they have less than 1% of the normal clotting factor levels. And the costs, as Cheryl said, can easily top $500,000 a year if not managed appropriately. This can more than double if the patient has an inhibitor. And I think the important thing to remember is not only is this a high cost disease, but if you have one, you might have more than one, as it is a familial disease. It's genetically passed. Next slide, please. So what are hemophilia treatment centers, or HTCs? Established in 1992, there are approximately 150 federally designated hemophilia treatment centers throughout the country. These HTCs have made a significant impact to care and treatment of these patients, as well as reducing the overall cost for payers. Next slide, please. So I sit on a group called the Comprehensive Care Sustainability Collaborative, or CCSC, and we've done kind of some deep dives into the health economics of HTCs. And a study in 2000 done out of Indiana and published in Blood and Hemophilia magazine saw that patients managed via the HTC integrated care model benefit from 40% reductions in mortality and hospitalization and a 47% reduction in ED visits. This is data from 2000, but it was actually repeated in 2017, and it still held true. Next slide, please. In addition to that cost savings generated by reducing healthcare resources utilization, patients managed by an HTC may experience lower annual costs through rigorous factor assay management and 340B drug discount pricing. So most of our hemophilia treatment centers have access to the 340B program. Well, they all have access to it. Not all HTCs have internal pharmacies. Some do rely on contract pharmacy models. But one of the things that all of our HTCs work very hard to do is reduce the cost of care, utilizing that 340B savings, not just to support the many services that our centers provide, but also to give back to the employers and kind of reduce that overall cost of care for patients. Because we do see, as Cheryl said, when you put a steep financial barrier in front of a patient, they tend to abandon those medications at the pharmacy counter and not treat their disease. Next slide, please. So if we're looking at what treatments are available currently, we've got clotting factor replacement. And when I came in to this space, this was all we really had. So you have standard half-life products. These are your lowest per dose cost. They're dosed up to 3 times a week. I will say what we've seen on these products is sometimes they're the lowest per unit cost, but you may actually end up paying more for a short standard half-life factor than some of the newer long extended half-life factors. So with those extended half-life factors, and again, this is replacing the clotting factor that the patient's missing, you can dose as infrequently as once every 2 weeks. Again, higher per dose cost, but it can actually be lower overall cost. What we also see on these extended half-life products are that patients tend to be more compliant on these products because the treatment burden isn't as high. All of our clotting factor products currently are IV drugs. So they're actually, patients are starting an IV on themselves and dosing in their homes with these products usually. We also have some bypassing agents. These are going to bypass those missing factors. They're going to bridge that missing domino to keep the cascade going. And in some of these products are actually a subcutaneous infusion or injection. So they're just going to go right under the skin, makes it a little bit easier on the patients. There is one other category that we don't have on this slide, and these are the rebalancing agents. These are a newer product that really hit the market this year. They, instead of replacing the clotting factor that the patient's missing or bridging that factor, they actually stop the natural anticoagulant in the blood. So they balance that teeter-totter a little different way. Those are less common. We haven't seen as much uptake in those products yet, but we will see those start to come to market as well and really see more prescribing of those. Next slide, please. Gene therapy. This was a huge deal 3 to 4 years ago when we started hearing about gene therapy products for hemophilia. I will say there were 3 gene therapy products that were put to market. 2 of those products have been removed from the market. Currently, there's only 1 gene therapy product for hemophilia B available, and it is a one-time, one and done cost. You can only get it once. It is a viral vector, so once you've been exposed to that virus, you can never get it again. One dose of this drug is $3.5 million, roughly. So that's a pretty significant outlay for an employer. However, if you've got one of those inhibitor patients that are running you or probably $1.5 million, $2 million a year, all of a sudden that 3.5 has a pretty quick ROI. Next slide, please. So we've talked a little bit about what an HTC is, what we're here for, what therapies are available for these patients currently. Let's look at some of the challenges that they have. Next slide, please. Prior authorizations. Prior authorizations have a place. They absolutely have a place within plan design to stop ineffective treatments or less cost-effective treatments when there are other alternatives. However, really when you get into a rare disease state where there aren't a ton of products available, prior authorizations can be counterproductive. While they're intended to ensure drug therapy is medically necessary, clinically appropriate, and aligns with evidence-based guidelines, when they're implemented in a way where 90% of them are approved, it actually will create a delay in the patient getting care, sometimes intentional, sometimes not. But what that can do is lead to frustration for both the patient and the clinician, as well as significant treatment burden. So if you look at a hemophilia patient, when they bleed, it's not that they're bleeding because they've had an injury necessarily. They can have spontaneous bleeds. Those bleeds typically will target the joints. Every moment that blood sits on that joint tissue, it's actually deteriorating the joint tissue. So if you have patients that continuously delay treating those bleeds because they're waiting for a prior authorization that's going to ultimately get approved anyway, you're actually deteriorating that joint so that you're seeing patients in their 20s and 30s need joint replacements because they're not treating those bleeds timely. Next slide, please. So again, consumers whose insurance problems include prior authorizations are more likely to experience serious consequences. We talked about the joint bleeds. So of those experiencing prior authorization problems, 34% of them were unable to receive the medical care or treatment recommended by their provider. 32% experienced significant delays receiving that medical care. 26% experienced a decline in their health, and 37% ended up paying more for treatment services than they're expected to pay. What's important here is it's not just the patient that's paying more, it's also the employer that's paying more in a self-insured plan. Next slide, please. Nearly 15% of all claims submitted to private payers for reimbursement are initially denied, including many that were pre-approved to move forward through the prior authorization process. These denied claims tend to be more prevalent for higher cost treatments. The average denial pegged to charges of $14,000 and up. With a hemophilia patient, if you're talking a severe hemophilia adult, you're looking at $30,000 to $40,000 per month easily. So they're very clearly hitting that target. Over half of those denials were ultimately overturned, and the claims paid, but only after multiple costly rounds of provider appeals. I will tell you, in our treatment center, I have 3 people who do prior authorizations only, and then appeals when those are denied, either pre or post dispensation. So when we're looking at what really drives up cost, the more employees we have to put on this for something that's ultimately going to get approved, the higher the cost that we now have to charge for those services and those medications just to cover that cost burden that we're taking on. The average cost incurred by providers fighting denials is $43.84 per claim. I would say that's probably low when you're looking at our hemophilia claims. But even with this number, providers are spending over $19 billion a year just to adjudicate these payer challenges. Next slide, please. So again, the consequences of a high patient cost share, we've seen a lot of movement in the last probably 5-6 years to accumulator adjuster programs and copay maximizers. If I have to pick between the two, I'll pick a maximizer any day, because when we really saw these accumulator adjuster programs come in, this is what we were seeing. We were seeing abandonment rates at 27% for specialty brands with deductibles versus 9% on a no deductible. These are causing increased non-adherence or even discontinuation of therapy, which we just talked about how that can actually cause more damage and progression of a disease state much faster than necessary. Financial toxicity, the medical debt that our employees will take on in these situations are not small. Patient concerns regarding accumulators. Many patients aren't given notice that these are put into effect until after a pharmacist points it out. I've had multiple patients call me and say, there's something wrong with my copay assistance. I went to my specialty pharmacy and they said that they can't give me my drug until I pay them my full deductible and max out of pocket. And I said, okay, let me look at it. And we find out that there's an accumulator adjuster in place that the patient was unaware of. Next slide, please. Alternative funding programs, when we talk about all of the patient cost share strategies, these are the scariest ones to me. And unfortunately, they're pitched to employers as the best for patients and employers concurrently. These function in several ways, but all versions look to redirect the patients away from the health plan to manufacturer patient assistance programs, or PAPs. These PAPs are intended for uninsured or underinsured patients, and their finite pool is subsidized by manufacturers to serve as a stopgap until other coverage can be secured. If a patient is approved for the PAP, they're provided drug free of charge from the manufacturer. I say free of charge very tenuously. It's nothing in life is ever free. Those charges are baked in on the back end to people who are paying for the drugs, and it leads to a higher overall drug cost. But even when those patients are approved for the PAP, which they're not in most cases, if they're approved, their time for approval is 68.1 days. 68.1 days of delaying care for cancer, multiple sclerosis, hemophilia. We're not talking disease states that are inconsequential. Hemophilia, it's over 80. And I will tell you, in our practice, we see 9 times out of 10, they are denied access to the PAP because these manufacturers have now figured out what's going on with this, and they're changing their rules for their PAPs to where if they find that a patient is insured, they're no longer eligible. What that does is it leaves patients with absolutely no options to access care. I have one patient that we see who has alternative funding in place by their plan. It's a self-insured plan. That patient not only does not have access to their medication in the outpatient setting, they have no inpatient coverage either. And in talking to the employer was completely unaware that this is how their plan was set up. Next slide, please. So we've talked a little bit about this, and I know it's a lot and it's a lot really fast, but there are a couple recommendations that are out there and published. MASAC is a medical and scientific advisory committee of the National Bleeding Disorders Foundation, and then ICER, the Institute for Clinical and Economic Review. MASAC and ICER have made recommendations when discussing hemophilia coverage in ensuring that coverage of prophylaxis treatment is a level adequate to provide bleed protection. What this means in the real world is that all patients should have at least 1 major dose and 2 minor doses on hand outside of the regular prophylaxis, so that when they do have those bleeds, they're not waiting for a prior authorization. They're not waiting for someone to get drug delivered to them, because I can tell you if they're using a large specialty pharmacy, that drug could take 3 to 5 days to get to them, depending on where they are in the country. If you've got, as we have in the Midwest, weather that likes to snow and then be 70 in the same week, that creates other barriers. They also say if utilization management programs such as prior authorization or step therapy are in place, employers should ask their vendor what clinical criteria are used for these. Are there patients experiencing a delay of care when stepping through the utilization management? Could there be unintended medical consequences or cost due to that I would say yes to both of those, but this is a discussion to have with your vendor. Consider comparative clinical and economic evaluation of prophylaxis treatments. So, not only looking at just one piece of the pie, but also how does that treatment burden change? What likelihood is there that the patient's going to use that medication as directed? Consider requiring management of prophylaxis to be done by or in consultation with an HTC to better manage costs. One of the things that I didn't touch on is how the HTC team works. So we have an entire team that is integrated within our system: physicians, nurses, nurse practitioners, a dietitian, a physical therapist, a immunologist in some cases, and our pharmacy team, and they're all currently integrated together. That allows us so many touch points on the patient that you're not charged for as an employer. It also allows us from a pharmacy perspective, when they're utilizing the integrated pharmacy, to do some additional management of those patients. When we're looking at that prophylaxis, we're looking at those on-hand doses. We're doing med recs every month to make sure that the patient has what they need, that if there are any bleeds, we've recognized them and talked to the clinical care team so that we can address repeated bleeds on the front end rather than waiting for the patient's one annual visit or every 6-month visit. And MASAC and ICER also recommend that you explore innovative approaches to covering high-impact single-use therapies such as gene therapies. We've heard a lot of different strategies around gene therapy. Again, I don't think it's had the uptake that we thought it was going to years ago, but there are ways to really structure those agreements that are based on performance of the gene therapy product, if that's something that you're looking at. And I think manufacturers and payers are kind of working together on that. So that's exciting. This was a lot of data very quickly, but I would absolutely tell you to please check out that action brief that Cheryl's going to give you access to at the end of this, because we put a lot of this in there and a lot more information. And if you don't know where your HTC is in your area, there are resources within that action brief that will direct you to the CDC's website to find the closest HTC to you.
Becky, that was excellent. And I loved the slide on the coverage denials. And I think all employers need to look at that. I really love the slide on the alternative funding programs, which I cannot believe are still around. And I know that we have to ask our vendor partners the right question. And you've got the second bullet here that covers some of those things. I'm pretty sure the action brief includes a lot more that are absolutely critical. Thank you for your help with that. We have a big cell and gene therapy project that we've been working on for years, and we know that there are curative therapies out there, and it's relevant to bring up that, yeah, for hemophilia, there's this one $3.5 million gene therapy, but it's curative. And that's the key.
It's not.
That is not curative?
It's not curative. No. It's a one-time therapy. You can only get it once. But right now, I think we have 7-year published data, and it does still show a decline in the trough or in the factor 8 level or factor 9 level. Sorry, that's the B drug. So we can't call it curative yet.
My bad. But we have some data. Did you include any of that data, or can we get access to that data so employers can look at it? Because if you're going to have a curative therapy, you're going to have a warranty or something tied into that, and certainly have the data on cost. So if you have anything you can share with us, that would be very, very helpful. It may be in the action brief, and I just forgot. But I know you're going to stay with us a little bit, and if you have any questions for Becky, please submit them via the Q&A function because we're at time. But thank you, and stay in there, and let's bring up Ariel. Let's come on and join the group. Hi, Ariel Waters is the mother of a 3-year-old with hemophilia, and she will be sharing with us the real-life journey that she and her family have been on, navigating the complex realities of hemophilia. She'll also share her thoughts from a caregiver perspective, and as an employee who had to navigate the complicated world of benefits in order to get the care her son needs. She has firsthand experience of the challenges an employee faces when their employee employer doesn't have a supportive benefit plan in place and the impact it can have on a working mom. But she also has positive experiences to share now working for an employer who provides best-in-class treatments, including care through a hemophilia treatment center. I love that she shares she's a Minnesota native living north of the Twin Cities with her husband and toddlers. And I don't see it in here, but I believe you called them feral. And then you have a sassy cat, and I wanted to include that. Ariel leads the global technology operations and software engineering team at SPS Commerce and is also on the board of directors and a treasurer for another organization, TEDx Minneapolis. She's a busy mom, working a full-time job. But when she gets a spare minute, you'll find her at a coffee shop reading a book or hiding in her car so she can eat candy without having to share it with the kids. Way to go, Ariel. Thank you for joining us today.
Thank you very much. Thank you for having me. Yeah, so this is the first time that I've actually spoken about what happened more broadly. So thank you for letting me share this with you today. My son, Atreus, he has hemophilia A. He is a moderate, and he just turned 3 this month. So um, something I want to start with is back in October of 2024, I went to my first local gathering for families in the bleeding disorders community. And during one of the information sessions, I learned that around 30% of people diagnosed with hemophilia have no family history. It's just a spontaneous genetic mutation. I couldn't tell you what happened during the rest of that session because I just couldn't get over that fact. And that's because hemophilia has been a known entity in my life. My father was diagnosed as an adult due to just a sudden bleed that started. He was diagnosed a few years before I was born as a mild hemophilia. So it's always been a part of my life. He just has always been involved with my siblings and I, teaching us about it and growing up with it. He's very open about hemophilia. So when my second son, Atreus, was born in 2023 and he got his diagnosis, it was confirmed 5 days later. At the time, the hospital confirmed it at birth via cord blood. And so our local hemophilia treatment center confirmed that and got us into their program and just wrapped their arms around us to help us get moving. So, having grown up around hemophilia, I thought I was prepared. I knew the language, I knew how it worked. I had educated myself as much as I could when my husband and I were family planning. What I wasn't really prepared for was how medical insurance was going to rock my world. And it was a very, very fast education on navigating this space. So not long after that gathering in 2024, we had open enrollment for my company and my husband's company around the same time. We were comparing our two employer healthcare plans. And his had a lower max out of pocket, and the costs just seemed that they were a little bit better. And so we thought that that was good enough, and so we went with his plan. 2 weeks after that, my son had his testing because, as I understand it, before they're 2, their levels can adjust slightly. When they tested him, he came back at 4%. So he is solidly moderate, meaning it wasn't about if he would have a bleed. It was more of like, when is this bleed going to happen? We need to get on preventative therapies. So the hospital sent over the prescription and we waited for the call to get it delivered. And that didn't come. So instead, we got a generic denial letter that the medication wasn't on formulary, so it wasn't covered. Before this, I didn't know what formulary meant, so I had to Google it. So it was definitely a bit of a shock. Um, Before I go any further on that situation, I do need to call out Children's, our HTC. Like I said earlier, they wrapped their arms around us and they were with us every step of the way going through this process for each denial. They were a phone call away. Everything I asked, they did. They even helped me find research papers on, the medication we were trying to get and the outcomes for those who didn't get preventative medicine. Like I got everything. So I really have to call them out for that because they even helped us find um, other areas who might be able to help, advocates, even got us in touch with the manufacturer of the medication that we were trying to get a hold of. Um, so for the appeal process, that became my part-time job. Documentation to this insurance company had to be sent by fax. There was no feedback loop or anything on that note. There was just a general customer service line where everyone could only tell me, I'll look into it and get back to you. No one ever did. I called every week. I started Googling. I learned everything I could about insurance, and I went down those rabbit holes. And I got to the point where, at mid-January, I was calling almost every other day, and I finally learned to ask for a supervisor, and I found the legal statutes on the timelines that you have to have your appeal done by. And so I threatened to call the State Department of Insurance for where that insurance was hosted. And then I finally got an answer within a couple days. A supervisor called me directly to tell me how lucky I was to receive a denial letter by email instead of having to wait for snail mail. Um, that second denial was pretty crushing. Um, by then it had been a few months and we were still spinning our wheels trying to figure out how to get my son medication. We just didn't want him to go through a joint bleed. He was 19 months old at the time. Um, I'm going to be blunt about what life looked like at home. My husband and I had serious conversations about getting a divorce on paper just so that I could trigger a life event. Because my employer, in going through this process, I had talked to them about what happened, their benefits team, and they did so much legwork for me. They found out that everything was covered, everything that I wasn't able to get on our current plan would be ready to go. And they kept in contact with their broker and made sure that like they kept in constant communication with me. So I knew that we could get it. I had it at my employer, but I wasn't able to access it because it wasn't in enrollment or anything like that. So we talked about maybe we just need to get a divorce on paper because that will trigger a life event. My husband wasn't really keen on that, so I got really desperate and I started drafting a resignation letter to my employer. I thought maybe if I quit, wait for my job to be reposted and reapply, maybe I could potentially get that back. If I couldn't get it back, hopefully I could still get a job at the company and have access to that insurance. I was just so desperate. Ultimately, it didn't come to that, thankfully, but yeah, it was a very frustrating and traumatic situation. I mean, I was so angry at my husband's company that I actually went on a campaign to convince my husband to leave his company, that we needed to go to a different employer. They were empathetic but unhelpful. And so it was just such a frustrating situation and I just felt so helpless. I didn't really know what to do. Now, his employer did catch wind, I think, because he did start looking, and they actually came back and gave him a quite a significant promotion with some perks because they really wanted to keep him. So while I'm still sour on that company, time has calmed down a little bit, and I know they care. It was just a very terrible situation. Um, so there was questions that I wish I would have asked going through this whole process. Does the plan cover hemophilia treatment center? Is it a network? Are the therapies and infusion services that might be needed covered? Are the specialty pharmacies you might need to use to get that information available? Are they covered in network? Is the plan a self-funded plan? Because if it is, there are additional limitations as a individual trying to seek help with getting coverage or going through those processes. Um, what state is it the insurance hosted out of? Because that is how an individual might know, okay, what laws, what state rules do they have to abide by or things like that. And these are the things that I learned in that process. Um, Throughout this process, I had been in contact with the manufacturer of the medication, and they were so great. They found some assistance programs that we could apply for. So while fighting those appeals, I did apply and we did get on the assistance. So by the time we got our our third denial, it was our second appeal, and our insurance company told us to that we couldn't do anything anymore. We'd exhausted our efforts, and they didn't really want to talk about it anymore. So we were able to get his medicine through the manufacturer, and that covered us for most of last year, and allowed me to just count down the days until I could get the insurance through my employer because I knew that everything was covered. Um, I reached out to our benefits team. I kept in contact with them. And then when it was time for open enrollment, I asked all the questions that I had learned from this process. They got me in touch with the contacts for the different areas, like the pharmacy section, the medical section, and we made sure together that everything that we needed was covered. And I got my own case manager immediately, come January of this year, who has been working with me. I mean, I have his cell number and he texts me just to make sure everything's good. I mean, it's total night and day experience. Um, and so, yeah, without the help of my HTC, the manufacturer of the medication, I don't know if we would have gotten it before I was able to enroll in our current employer plan. So it did end on a positive note. It was definitely a little bit of a traumatic struggle during it though. And looking back now, I think it's just so wild that I went to those extremes. But at the time, um, you know, I didn't want him to have a single joint bleed. My dad is a mild hemophiliac, and he had a joint bleed as a kid from when he had he broke his arm. I think he was 8. Um, and he had just had uncontrolled bleeding in the joint, and his arm never fully recovered. He's had physical therapy and surgeries. He's in his 60s, like he's never been able to straighten out his arm, and it just looks so atrophied at places. The nerves were damaged a little bit. It's just, I don't want my child to go through that as a teenager. So yeah, that was our experience.
Well, that was fabulous. And I think we have a few things we want to share. Walk us through who this little guy is. He's absolutely precious.
Yeah, this is Atreus. So this picture was in 2024. He had an incident with a couple of steps, and so this was before we actually had Factor at home. And I was surprised by how easy it was to get Factor, but hard to get the preventative. So yeah, they had to administer it in the hospital, and so he sat there and was just zombied out by the TV, so excited. And then on the right side, he is definitely a big personality, loves to showcase. And so he was pretending to be a jazz player because he thought that was so cool.
That is adorable. Here's a couple more superhero, right?
Oh yeah. Yep, that's I think this picture with the cape and the glasses, that is his personality in a picture. So,
I love
yeah.
it. Ariel, thank you so much for sharing this important story and your unique perspective. And of course, being a champion for your son, you did an awesome job today. And I love that you shared that making sure that hemophilia treatment centers are covered in network as like a first step. And in knowing that you have that in your plan, and also being reminded that you need to know what's in your state rules. And you gave some of the employers on the call today some ideas for other ways to do this. Please stay with us. We will be opening the questions up when we're done with our employer panel, and thank you so much. All right, we're going to move on to getting some perspectives from two of our leading employers who are here to share what they learned as part of this important project. And I'm going to start by asking them to each briefly introduce themselves, and then we'll get started. Welcome, Nicole and Carol.
Hello.
Nicole, do you want to get started since you're on the left on my screen?
Yeah, I don't know how I got in front of Carol from an alphabetical perspective.
Alpha, yeah.
Hi, I'm Nicole Martell. I'm the Chief Rewards and Wellbeing Officer for Bon Secours Mercy Health. We are a faith-based health system based out of Cincinnati, Ohio, but have presence in several states in the US, and then have recently expanded our footprint in the Ireland and Philippine markets.
Thank you. Carol?
Hi, Carol Mendoza. I am at HP. We're the people who make computers, printers. We own Polycom, so all the conference room things that you were used to before the pandemic. I so appreciate being a part of this project. As I've told the team, I think as benefits leaders, we know if we have hemophiliacs on the plan because there's a significant cost. Back in the day, it was $1 million for every hemophiliac. But I think we saw them on our list of high cost claimants, but didn't really think that we could do anything to impact the care or impact the cost. And what has been really helpful for me through this project and listening to Becky and others is that there is so much that we can do to help encourage better outcomes for patients. This lovely side effect of that is that we can save cost for the company too.
As well as reduce rub in our plans. There's ways to partner actually with our vendor partners in a different way to create a better associate or employee experience or member experience.
Yes, well, and that's a really good point because if it's not the employee, it's a family member, the employee is still having to deal with all of the stress of managing this, everything that Ariel was discussing. And, we want people to be able to work. Most importantly, we want them to be able to support their family members, but all of the time that's necessary to navigate the system when it is fractured and fragmented has an impact on productivity. And we don't want anybody to go through that.
Well, and I think we also want every employer in this country, regardless of size, to have the tools and the questions that they need to find out what they have and then work around that. I'm going to start by asking you to share your thoughts, your reactions to Ariel's story and the impact of plan design on the member experience and potential unintended consequences. What that journey looked like on your own when you first started this, maybe with another organization, and where you're at today.
I think it's just heartbreaking to hear that someone would have to go through that and that through well-intended, though well-intended, some of the things that we have in our plans cause so much friction and create such traumatic experiences for our employees and their family members. And like PAs, for example, and something that we talk about in the pharmacy space, but it certainly applies here too, is when we have a PA in place, how many times is that getting approved? And if that number is high, why do we even bother to have the prior auth in place?
Right. That's right. Yeah, where my head was going is I'm like, every time I heard her, or when I heard her say something to the effect of that she was going to create a life event, I was like, oh boy, we try to avoid those kind of things. We want the best associate and member experiences we possibly can in our plans. And I think by and large, most employers actually feel that way. And so to have a less than amazing experience was super sad for me. But I also think actually the employer briefing that's been put together helps to address some of those things. So if you don't, as an employer today, have something in place to really help these patients when they do surface in your plan, the 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 work that we've done to put together the packet will be super helpful to any employer.
Thank you. What kind of clinical evidence are you looking at or prioritizing when you're determining coverage for hemophilia?
So within our plan, we do not have a hemophiliac, except for we have an acquired case, which is very different clinically, how it's managed, how it surfaces, when it's actually identified. But for that particular associate, she's using our domestic facilities. And so we have actually a gold carding project program in place for any domestic providers and facilities. So that helps that member. In addition to that, we have a care manager or a population health manager working actually with that patient. That was something actually that because of this particular work, that surfaced as a need that we hadn't identified her for our population health outreach. But she now has a case manager working with her. And then in addition to that, our pharmacy team does a lot of hand holding with specialty medications. And is also taking care of this patient differently. So we really wrapped around the one patient that we identified through this process.
And real quickly, I know what it is, but I didn't know what it was for a long time. What is gold carding?
Basically, we trust the providers within our own domestic network to allow for no prior authorizations to be submitted. Now, we don't allow that for non-domestic providers, but our own providers, we have clinical criteria and quality criteria that they have to abide by. And therefore, actually, we monitor them on the backside from a quality perspective and don't feel that they need to be monitored through a PA.
And for a traditional employer, that wouldn't be a health plan. That would be having a network of providers that would do the same. Okay.
A high performing network. Yeah.
High performing. Excellent. Carol, how about you?
Yeah, and something that I learned, and Becky could probably speak more specifically to what are included in the guidelines, but we have it in the action brief, a list of guidelines for the specialty pharmacies to ensure that they are dispensing the medication properly, the treatment properly, and then just making sure that the care management that wraps around the patient is evidence-based. Is really critical.
Well, and the other thing that came to mind is it's not just actually what's in the medical plan, but it's all the other services that you have within your benefit suite to wrap around. So as I was hearing Ariel talk, I was like, oh, I would make sure actually we had our mental health solution wrapped around that associate. I'd make sure that we had the caregiver benefits that we have available, make sure that that person's aware of those. So there's a lot of other touch points within our benefits suites and offerings that I'd want to make sure we're being connected actually into.
That integration is so important in this environment. What is the role of your benefits consultant for both medical and pharmacy in determining these plan design strategies?
So ours are an integral part of our team. In fact, I don't know that I would consider them actually our consultant, but more of our team members. They really serve as our extension, both on the clinical side as well as on the plan administration side. But in this particular case, I went to them to ask like what should we do, and they came up with actually like the action plan. I identified several things for them, but they came up with additional things for us to do actually to make the member experience better. And then the other thing that this actually triggered for us is how do we then build actually a referral pattern into HTCs, because we didn't have that built with our care managers or with our care navigation company. So making sure that we actually had that in place too.
How about you, Carol?
We have terrific consulting partners, although sometimes I'll hear something at an MBGH event or talking to a colleague like Nicole, and like I bring things to them like, oh my gosh, she's been off listening to something again, but so I brought this, and then that's when we started. So they had not identified this as an issue. We have one patient, and while the patient is well managed, still very expensive, I think we needed to prepare for the next one so that there is a good experience.
Well, and I have to bring up the smaller self-insured employer, and they're probably working with a broker and probably not getting the same kind of feedback that you're getting. So what would you recommend that they do? Are there a couple things that they could do? Maybe it's to make sure that the HTCs are in network and covered, or if not, make that change. But I mean, the smaller employer is the one that would struggle the most in this case. Any thoughts on that? Is that about on target?
I teased you about pearls, Cheryl.
Yes, my pearls. I love. I'm not wearing them today.
I've been teased about being pragmatic. Apparently, I say that a lot at MBGH events, but I think the employer action steps in the brief that's being released is really good. And one of the things that you suggested was making sure that there's at least one hemophilia treatment center in network, but then we also have there about the specialty pharmacy guidelines, looking at your data to understand what kind of exposure you have. And then, as Nicole mentioned, making sure that all of the partners in the ecosystem are working well together and holding them accountable. So read the brief.
Yes.
I agree. And go ahead.
I would not add anything else to that. I think the brief, we did a very thorough job. I mean, we sat on a group of there was a group of employers where all of us had very limited information going into the project. So it was really a refreshing project to hear about where we all had opportunity, not just actually where one might be doing it really well and the rest of us are lagging. I think we all felt like we came out of it with something, a nugget to take home.
Yeah.
Nugget, that might be my new pearl word. I don't know. We'll have to see. So what kind of potential barriers or obstacles do you anticipate or have you experienced in developing this ideal hemophilia treatment coverage plan for your members? What were the challenges you faced? How did you work around them?
I think getting attention on this, because you're planning for one or two patients when and if they develop, in a population of our size. So the way I approached it is thinking about any significant health issue and how would you want to make sure that the patient was managed and that the family was supported. So in this case, it happens to be hemophilia, and we, make sure that HTC is in network and that you do these things. But there needs to be a similar path for any significant medical diagnosis. So we're not only treating one patient, we're talking about hundreds of patients, and we need to satisfy their unique needs. And that's how you get the attention of your carriers and partners.
Yeah, I think balancing it with the high volume, high cost items versus the low volume, high cost items is always a pressure point for people who are in our seats. And so where do you focus your energies? And if there's some way to scale an approach actually across multiple low volume, high cost conditions, that's probably wise.
Very good feedback. What else did you learn by participating in this project? What were the pearls? What was the word nuggets? And what are you going to do differently, or what are you doing differently after you kind of went through this process? You alluded, Nicole, yeah, we all walked away with nuggets, but what are you going to do potentially differently or think about things differently?
That scale thing was really my big aha moment that I had was how can we apply this to low volume but high cost conditions consistently and thoroughly. That's kind of what I've challenged my team actually to start thinking about.
Mm-hmm.
And for me, similarly, looking at the patient journey for these significant diagnoses and what, you know, probably unintentionally are we making people go through to get coverage, and what makes sense and what doesn't. And then similarly, looking at our high cost claimants more holistically and kind of doing a grand rounds,
Yeah.
get someone with
Yep.
clinical expertise to say what went well and what didn't, that we can fix for the future so that other patients, regardless of diagnosis, don't have to go through this again.
Yeah.
And just a reminder that in a few years, you're going to come back to us with that, or in a year, and say, this is what else we've done, and we'll get that in the action brief. Nicole, you started to say something? Sorry.
Yeah, I think I'm in a unique position in that I work in a healthcare system. So one of the things that I also took back was an opportunity to connect Becky with actually our clinical leaders to say, create awareness actually within the provider community of HTC so that they're a referral pathway for them. So that was probably one of the bigger takeaways from me, but I'm in a unique position.
Well, I mentioned earlier that we have our cell and gene therapy project that I was naive in that I thought that this $3.5 million therapy was curative, because that's the world with these really, really high cost multi-million dollar therapies that they are. To learn from Becky that, we're still kind of waiting for the research to happen. Um, uh, because this is one of those really rare and high cost diseases. We talked about the top things that you could do. Anything else come to mind besides making sure your vendors have the right plan design in place, that they're covering HTCs, that they're doing the things that both of you have just talked about? What could the average employer in this country, what would that number one thing be?
Know your data.
Oh, yeah, always, right?
Well, and one of the ahas for me was when Becky talked about how much of the factor was ordered versus shipped, the doses, and how much waste there is in that process. Yeah, just eye-opening for me. And if you can get to that level of data, and again, Becky can speak to it better than I can, but there's a lot of waste in the system that isn't helping the patient.
I'm going to ask that Becky and Ariel bring their photos up, because we have a question, and I'm encouraging any others of you that have questions, this is the time to share them. But Becky, do you want to respond to that question on waste and ways that employers can do something about that or work with their vendors? I don't know if it's a matter of the vendors want to send. I remember in the first round of this project, they like to send a lot of extra because they make a lot of money on that. So what can an employer do about that?
Yeah, so I work with employers a lot on this. And one of the first things when I'm talking to an employer about moving allowing the HTC to serve, is I say, okay, I want you to pull up your dispensation history. I want you to take out any cost numbers. You can see those. I don't need to see them. But I want you to show me how many units they dispense. And I'm going to show you the actual prescription that was written. And so we do a cost comparison, not only on a per unit cost, but also in that assay management piece. With some of these longer acting factors, you don't have as many assays to work with as we do in some of the shorter acting. But I always check and see, okay, what was available at that time? Because I have all that data and I'm able to see, okay, how would I have filled these if it were my pharmacy filling? The other piece is, how many doses did they send? Because again, we said you want one major and two minor bleed doses on hand plus your prophylaxis. What we see, especially with the big SPs and Unfortunately, you don't see this in the fully funded plans. It's only when they have no financial skin in that game and the employer's taken all of it, is those SPs will send out bleed doses every month, even though the patient has no reported bleeds. That's where that med rec is important. My pharmacy technicians, when they talk to a patient, they say, how many doses do you have on hand? And if the patient says, well, I have 2 doses, they'll say, well, we show that you should have 4. Have you had any bleeds? And then it opens a conversation. Conversely, if they say I have 4 doses on hand, which equates to 1 major and 2 minors, we don't ship anything besides the prophylaxis. So we're really managing that tightly, whereas the larger SPs, or even honestly some of the smaller ones, aren't as conscious of your money when they're sending those. The other piece we see is in some of the drugs, they're single-use vials, but you don't use all of that vial. And what we've found is sometimes they're filling a larger vial size than they need to. And so that's another way that there could be potentially waste in there. It's hard for us, like if I'm dispensing a 250 unit vial and I only want the patient to use 212, I have no way to just give them 212 units. So I have to charge you for that 250 unit vial, but it would be irresponsible if I then charge you for a 350 unit vial instead of that 250. So we see some assay management there.
Any comments from Carol or Nicole on that? And then Ariel, I want to get your feedback on what your experience is in that. Carol, Nicole, any thoughts? Any things that you're doing to address some of those issues?
Well, a question for Becky. If you mentioned 212 milligrams, right? What if the patient received 350? What happens to the leftover? Is it tossed? Is there a risk that somebody's going to take extra and something bad is going to happen? What are the consequences? Other than the financial to the employer, which I think are clear, but what are the patient impacts?
Yeah, so that's a good question. It's possible that a patient could give more than necessary. In theory, that could cause a thrombotic event. It could actually cause a clot in a patient with a bleeding disorder. We don't have data to support where that threshold is. So I can't say definitively it would do it, but in theory, if you don't need it, it could do it. But the bigger thing is it's usually just thrown away. So you're literally taking money and just right down the garbage.
Nicole, additional thoughts?
Where my head was going is, Becky, and more of a question for you than anything is, where is there a care manager involved? Like, do you often see care managers involved actually with patients? And if so, can they help to control the waste that might occur?
So a care manager would be potentially able to tell the patient, in my experience with them, they're dealing directly with the patient. So they would be able to potentially tell that patient not to dose extra drug, but I mean, they're not going to be able to adjust what the pharmacy is doing necessarily, because the pharmacy is the one that's calling the patient, that's getting that information to them or from them on what they need, and then sending that refill through. I will say this is an opportunity. I think the HTC serving the patient completely is the best. That's our gold standard. But if that's not possible, at least making sure that the scripts come from the HTC, because I will say for myself, and I serve as the president of the board for the Hemophilia Alliance, which is a group of 104 of the hemophilia treatment centers throughout the country. What we tell our members to do, what we hear from our members that they do, is they're really working with those patients. So when the pharmacy calls for those refills, they're not just sending them blankly. They're reaching out to that patient saying, do you actually need these? So it's not as good as when it's the in-house pharmacy, because you don't have that direct back to the care team when there are discrepancies. But if you can't have that, that's your second best. Always, I will say, no matter what, across the board, clinical care should happen from the HTC. And I will say that Illinois Medicaid actually requires prescriptions for any patients on Illinois Medicaid to come from an HTC because of that exactly.
I want to make sure Ariel has a chance to share any experiences that she has had You've probably had to get rid of Factor. I don't know. But any thoughts on this?
Yeah, I would say our HTC has been pretty critical in helping us keep the right amount. Um, Before we were able to switch over to my current employer plan, the old insurance, they did let us keep Factor at home after a battle because our HTC is an hour away. So if he got an injury, there are no surrounding city hospitals with Factor that he would need. So they let us have some at home. And so one at home, one at daycare for that situation. We did have some that expired. Um, and so when we went to request non-expired doses for a new prescription, they didn't want to give it to us, but it was about 3 months before I knew we were going to get on my current employer plan. So our HTC advised us that, even though it's expired, it'll only be expired for a couple months, and you can just keep it on hand as like a fail safe so you have something. And after that, we could donate extra expired Factor to our HTC because they have a program um, with another country that it can be utilized, I guess, within a year. And so we just give it to them and then they go through that program. But yeah, that was something I was concerned about when it came to the prophylaxis because the bottles are just only certain sizes, and because he was so young, um, there's always a little bit of waste still, and I just feel so bad. Like that vial, it's less than it was, but we are at the smallest vial, so they try really hard to maximize what they have.
I have to bring up, first of all, if you have any questions, please submit them. I do have a question, Joe, thank you. Are there any federal programs or federal type programs similar to end stage renal where the government takes on the cost? Any commentary from any of you on that? Becky, I'm going to start with you.
Yeah, so the end-stage renal disease program is Medicare. It's taking those patients onto Medicare. And I think it brings up an interesting change in the hemophilia population. Not to date myself, but I grew up during the Ryan White era. And back in those days, our patients weren't living long. They were dying in their 20s and 30s, usually from HIV or hepatitis exposure. In fact, most of the patients my age or older have been exposed to one or both of those in their lifetime. There was a day that they weren't using prophylaxis because of that. And they were ending up on Medicare and they were on those government programs more often. Now, with the treatments that we have, Ariel, I hope your son never has to know a day that he's anything but a little boy. We have great treatments now, and keeping the patients out of those government programs is our number one goal. And so, yes, we have some patients that are on Medicare, Medicaid. There's not a specific program for it, but it really is our biggest goal to keep patients out of those programs and working and living their lives the way any of the rest of us are, and working for you as employers in their full capacity.
Any other commentary, thoughts? So I'm going to come back to the question of waste. Becky, does anything come to you based on the things that you shared earlier that employers need to be aware of and what they can do about it?
Yeah, again, I think just doing those audits of your PBM, even if it's the HTC. I have employers that I work directly with. There's a large national employer that I have a contract with that they have one member. If that member has a month that's exceptionally high, I give them a call. I reach directly out to their broker and say, hey, FYI, you guys are going to have a big month this month. Your member hurt himself in moving. We're dosing him. It's going to go away next month. So when you're managed through the HTC, especially the HTC pharmacy, you can get that kind of concierge level care. I was just on a group last night talking about this. It's a different kind of handholding than you would get with someone put into a larger pool of an SP. And I think it's because of that integrated clinical care. Ariel, it sounds like your HTC is very active with you guys as well. know your HTC very well, so it doesn't surprise me. They're pretty fantastic. But really, that's the level of care that employers can get. And if you're not currently with an HTC, there's an opportunity to reach out to one of these national groups. I know National Bleeding Disorders Foundation has a consultant that they use who actually helped make the original hemophilia toolkit. And now she's consulting for NBDF. And she can do an independent audit and really look at your claims data and help you understand where there is potential waste in there, where you can ask extra questions. Also, on the action brief and in the toolkit, we have some very specific questions that you can ask your broker partners to really open up those conversations. And again, I think reaching out directly to the HTC in your area, even if we're not serving the patient, we all have resources that we can share with you or get someone else involved from the national level.
Maybe that becomes one of the recommendations to reach out to if you're a broker or you're a consultant and you're not in this space, because Carol, you even talked about, them not maybe being where you thought they would be. So you worked on it together, which is wonderful. But that average employer needs to be able to also move that organization, whether it's a employee benefits consultant or a broker. I'm going to go back to the
Cheryl, could I pause you for
yes,
just a
please.
second?
Sure.
So as we were talking about waste, and I mentioned it earlier, but I thought Becky could add to it. And I'm not sure I'm pronouncing this correctly, but the MASAC 188 guidelines. So we say in the action brief that people should talk to their brokers or consultants to confirm that the specialty pharmacies are adhering to those guidelines. And I thought it would be helpful for Becky to explain what those guidelines ask for.
Put me on the spot. There are a lot of MASAC guidelines. So this one's specific to how many doses patients should have on hand. It's, again, that recommendation that they have 1 major and 2 minor doses on hand. It's really looking at how quickly patients should have access to that medication in case of a bleed. Ideally, in a perfect world, every patient would call the pharmacy when they have 2 doses left of their medication, give us plenty of time to work through all the The reality is that's not life. Things happen, life gets in the way. A bleed happens, and now you're all of a sudden thought you were good and you're up against a wall trying to get things done. If we're following the MASAC guidelines on doses on hand and what a patient really should have, it lessens the chances that you're in that space.
And I didn't mean to put you on the spot. I'm sorry. One
No,
of the
you're
other
fine.
things I think was in there too, if I'm remembering correctly, is that the amount that's filled is within a certain parameter, right? So it helps to address the waste as well, and that the pharmacy is available if people have questions. Yeah. So it's really something pragmatic, Cheryl, that's in the action brief.
I already had that on my little list of questions to ask.
Okay. Sorry.
Walk us through those guidelines for specialty pharmacies. So I'm really glad that you guys talked about that. And again, Becky, thanks for your help. I have to go back to the PAs and the maximizer programs and the AFPs. And what the heck? I mean, I thought they'd be gone by now. And I know that a lot of employers, as you said earlier, don't even know that they exist until something like this happens. And so I don't know if we're asking, included any questions that we could, can't think of it off the top of my head, to say to your PBM or your carrier, whoever is managing this for you, what is the process? What are you requiring? I'd love thoughts by any of you on that. And Nicole, have you gone down that pathway? Have you removed those barriers to your plan design? Have you ever experienced that in this role that you're in now? How we're addressing prior auths, the maximizer programs. You guys you're pretty sophisticated, the employers on the call. So you have addressed these things years ago. We had a maximizer copay accumulator and then this alternative funding program webinar like 4 or 5 years ago, but it's still out there. Just share commentary with me. And Becky, I'll start with you because how can employers find out if they have that as part of their plan, and how can they address it? Does that mean they have to change vendors?
Yeah, absolutely. So I remember when I prior to my position here, I was CFO of a company that had 33 KFC Taco Bell locations. And I ran our 400 employee self-insured plan. And I remember our broker coming to me and saying, hey, we want to save you some money. Always sounds great. And they said, you have 2 patients on your plan who have HIV. If you cut access to HIV as a covered benefit, you're going to save $3 million this year, which sounds great. Except I'm like, well, how are my members going to access this benefit? Like, how would they get their medication? Because obviously you can't go without it. And they said, oh, no problem. We'll hook them up with a free drug. This was before AFPs were a thing. This was just exclusionary. We've seen these AFP vendors take this to another level. If you have a broker that's presenting something to you as, we're going to help you find alternative sourcing to your drug, we're going to help you utilize manufacturer assistance to pay for these drugs, that is alternative funding. And what I can tell you is, again, the delay in care on patients for that, number one, I would argue that it's putting you at potential liability. We've had some discussions with DOL and CSIO on their opinions, and there's been some real interest in this from the federal government side and with legislators, because we're taking these patient stories to them of what's happening, what it means for our patients, how they're going without care. Anytime somebody says something for free, that's free, it's probably not. Free doesn't exist in this world. So if you're getting that from your vendors, the other piece is importation. I've seen a lot more of that come up. In hemophilia drugs, technically they cannot be imported because they're biologics, but we still have vendors saying that you can import them. So if someone's talking about importation on hemophilia drugs, that is 100% alternative funding, and it's not actually legally possible.
Loves feedback from either of our employers, and Ariel, if you've had any experience on, well, I think you have on some of these programs, but Carol and Nicole, any thoughts on this? Any thoughts about workarounds for employers?
Fairly unique in this area because we operate our own PBM capability internally with our own pharmacy capability, with a mail order and a specialty pharmacy that handholds people through processes. And so I'm not sure my takeaways. I mean, we do have coupon programs. We also have variable copay programs in place for medications. But they handhold the person through it. So to Becky's point, they try to reduce the delay or eliminate the delay by handholding the member. And typically it's not for the first fill. So it's actually for subsequent fills where you might actually have, multiple months or multiple on hand. But no, beyond that, I don't know that I have any other tricks in my bag right now.
Helpful, Carol?
Yeah, no other tips or tricks either.
Ariel, you experienced some of this with the original benefit, didn't you?
Yeah. So with the original, with the first insurance, I don't even think we got to the point of finding out accumulator or maximizer, just because the battle was just to get coverage for the medication in the first place.
Right.
But with this insurance, I did learn about it through the manufacturer, because now that I've been mobilized, any changes, I bring everyone with me. So the manufacturer's coming along for the ride, my HTC, my employer HR team. You are all going to be in the room and suffer with me, because the harder it is for me, the harder I'm going to make it for you. And I don't
love
know, I
that.
know that's not, what people probably want to hear, but yeah. The manufacturer got on a call with my new benefits manager and everything, and they like talked through it for me, and like in a lot of language I didn't understand, and we discovered that it was all good, that we weren't, because of the configuration, because my employer has several different plans, and then there's a third party piece, and then the drug provider. And so like the configuration I chose was to guarantee 100% coverage of everything we needed for that case. So we were good.
I love it. We talked, last question, we talked briefly, Nicole, you shared a little bit about how you've integrated your strategy, making sure that you're meeting the needs of the caregivers, making sure that behavioral mental health is integrated. Carol, you gave a few pearls. Becky and Ariel, is there anything you see out there that needs to also be integrated into this model to support that patient? Or Ariel, in your case, is there anything that you've seen missing that you'd like to see? And I'll start with you, Becky.
Oh my goodness. So I think looking at just supporting the patient, I will say the one thing, Cheryl, in working through with Carol and Nicole and our employers is it was very remarkable to me how much employers are bought into really what's best for their employees. And I think there's a disconnect there. So Ariel, I love that you're bringing your employer into this and your HR and benefits people, because that connection, and it is when we've dealt with alt funding or other things like that, when I reach out to the HR people, usually I'm like, oh, I didn't know this was what my employees were experiencing. So that education piece is huge. And I think, allowing our employees to see that they do have these champions in their HR department and in their benefits department who do care about them. They're not just a number. I mean, finances are finances. We all have to deal with them. But knowing that you guys do care about your employees, that you want what's best for them. And when you see these barriers, it really is something that you're working to try to get around. So I would say making sure that those relationships are there and that there's a clear pathway for that employee to get to the right person in the benefits department to have those conversations is huge.
I did throw a curveball at you, Becky. I'm sorry for that. Excellent answer. Ariel, anything you seem that might be missing?
I think in going through all of this, not even just hemophilia, any kind of complex or rare or even intensive chronic condition. I mean, if you can get that person a care manager, benefits manager, some kind of contact to like help them with the process in the beginning, I think it will prevent a lot of the stress. I mean, I was so dissociated from work at times, and the fact that I was gonna like blow up my career, like, I mean, employees think that you get irrational for your children or your family. So I think that would have helped. Probably could have used some maybe therapy going through that process. But yeah, I mean, and that's something that my current company did right away. Immediately, January 1, I got a text. Hey, I'm your new benefits provider. Here's my backup. I'm your care person, like I'm your main point of contact. And anytime I have an issue, like in our last uh, prophylaxis delivery, it's an injection, and they forgot the filter needle. And I texted him, I was like, there's no needle. And he just immediately got on, figured it out, and got one sent and just took care of it all for me. And that's life changing for me because, like, it just is so stressful when you don't have that. Yeah.
This
Yeah,
topic is life-changing. This topic is about life-saving. This topic is about little kids. This is so important. Thank you so much for coming and sharing your story. We've been talking well, first of all, let's thank this amazing, what do? We do this on calls when we're clapping. Thank you, each and every one of you, for your expertise today. Go back one slide. Well, maybe this is the next slide. Here were some other employer insights. Even if you don't have active claims, the costs are significant enough to start taking action now. You got to know what you don't know. Keep it on your radar. Being prepared will lead to the best results for the plan member. Going from diagnosis to right care, we want quality. If they don't go to the right place, it's a problem. Finance doesn't care about members' feelings or their cost share, but if a member is suffering, they will cost the company money. We heard about productivity. There's a lot of hidden soft costs the plan should be concerned about. And finally, if we don't get in front of this disease, things will cascade. These are actual employer quotes from this project. And the next slide, we'll learn just a little bit about the new resource we're launching today. Go to mbgh.org. You'll see resources in the menu bar, then click on employer action briefs. And then when we launch the updated employer toolkit, we'll let the group on the phone today know about that. Next slide. And then finally, this great resource, every one of our employer action briefs have action steps. So it's going to talk about the problem, how it impacts employers, what the economics are, what the challenges and barriers are, and how you work around them. Some of the employer action steps are built around looking at your current plan design, looking at the number of people that have hemophilia and the current cost to your plan. And again, even if you don't have it today, you may have it tomorrow. Hold your vendor partners accountable. That's one of the biggest stories to me as I've gone through this journey. Gain a better understanding of your financial exposure through data and the impacts to individual seeking care. Here's the link to the employer action brief. We will be sending you, so not only can you go to mbgh.org right now, and I believe it's on the rotating banner, it's the first thing, so you'll be able to click on it, but we will also be including the link to there it is right there. Actually, yep, there it is right there. And I also know, next slide, that the toolkit is coming soon. So you can see a quick overview of the toolkit that we launched a few years ago. Everything is being updated, but you can see how comprehensive it is. And then finally, we have a slide about our upcoming programs. We've got a great vaccine preventable diseases and reducing them in vulnerable, high risk and high cost members on June 2nd. June 23rd, our pre-forum workshop for our employer forum on pharmacy benefits and specialty drugs and CGTs is on high cost cancer claims. Deep dive and practical applications for employers. It's an employer only event. It's a half day. Bring your data. If you haven't gotten an invitation on it, reach out to any of us. June 24th, our biggest, second to our annual conference every year, which we just had a few weeks ago, and it was rock star, is our employer forum on pharmacy benefits, specialty drugs, and CGTs. We're in the middle of reshaping pharmacy benefits. So how are we as employers going to put the right strategies in place for that PBM transparency that is so important and the role of high cost therapies? September, we're finalizing the date. We're going to have a webinar on the burden of inflammatory bowel disease. We just launched an action brief on that. And then finally, on September 30th, we have the price transparency effect. Everything from how do you get your data, how do you focus on fiduciary to protect yourself, and then lost dollars. There'll also be fraud, waste, and abuse information included in that. Next slide. And thank you so much for attending. Don't hang up yet. We want you to complete this evaluation form. They're going to put a link in the chat right now. And there it is. You've got a whole 3 minutes to complete that form before we're done. And I'm always told, please don't talk through it. But those of you that are looking at it and you can continue to complete it while we're done, I just can't thank the employers enough for your passion about this topic and your passion today and helping us get these great resources in the hands of employers across the country. We don't offer these action briefs just for our members. We make them available to any employer in the country because that's how important these things are. Keep that chat URL with the survey up if you can. And then I want to thank Ariel again, who did such a wonderful job sharing the real life stories. So thank you. And Becky, outstanding information. Anybody that wants to reach out to her to learn more about what they're doing and how you can be supported by their activities, feel free to do that. And everyone have just a terrific, terrific day. And in a handful of days, we're going to have a holiday, so enjoy that as well. Thank you all. Bye.